Hello, my name's Florence. Welcome to the theobspod. I'm an NHS obstetrician, hoping to share some thoughts and experiences about my working life. Perhaps you enjoy Call the Midwife, maybe birth fascinates you, or you're simply curious about what exactly an obstetrician is. You might be pregnant and preparing for birth. Perhaps you work in maternity and want to know what makes your obstetric colleagues tick, or you want some fresh ideas and inspiration. Whichever of these is the case, and for that matter anyone else that's interested, the theobspod is for you. Episode 128, Meconium. Today I'm going to talk about meconium. What is meconium? Many of you will know it's effectively the first poo a baby passes. But it's not really poo in the way that we think of poo. It's the contents of the baby's gastrointestinal tract, its bowels, that's true. And it's contained there from about the 10th week of pregnancy. It's made up of water, bile acids, digestive enzymes, and cells, that is skin cells that the baby's swallowed, and cells of the digestive tract, and then also amniotic fluid and possibly hair. So it doesn't look like poo. Any of you that have had a newborn baby know that that first poo is kind of sticky and dark green in colour. And that is meconium. So why are we worried about it? So what I'm talking about today is when the baby has passed meconium at some point in the womb. And this is very common. The baby can open its bowels and pass meconium. If you look at data, it's somewhere between the region of 7 to 22% at term. And if you go to look at data after 42 weeks, so post-mature, it could be even as high as 44%. So if it's so common and it's the normal contents of the baby's gut, why are we bothered about it? Why am I about to spend an episode talking about meconium? Well, the reason is that rarely, 2 in 1,000 pregnancies, the baby will get what's called meconium aspiration syndrome. This means that the baby's passed meconium, yes, but that the baby has aspirated, inhaled that meconium or meconium-stained amniotic fluid, and that this has caused significant lung problems for this baby. In some ways, it's surprising actually that given the frequency with which babies pass meconium in the womb, that meconium aspiration is only 2 in 1,000. It's relatively rare, despite the fact that we see hundreds of babies every day that have passed meconium in the womb. So today I'm going to talk a little bit about what we're considering when we think about meconium and how we're trying to pick out which of the many babies that have passed meconium might be in difficulty and might have a higher chance of that meconium aspiration syndrome, and which babies have just passed meconium and are completely normal and not stressed and doing well, and therefore have a low chance of meconium aspiration syndrome. The first thing to consider is, why has the baby passed meconium? So passing meconium could be totally normal. It's part of normal development. As the gut matures, peristalsis starts to develop. Peristalsis is the movement of the muscle within the gut that helps pass the contents of your gut along the gut. As you can imagine, when you're a child or a baby and you're on the outside world, it's really important for stuff to travel down your gut. You're going to feed on hopefully breast milk, or when you're a bit older, food, and that food needs to travel down your gut for digestion to occur. So part of the passage of meconium can be completely physiological, the baby's body doing what it's designed to do. And this is why it's more common for meconium to be passed in babies at term, so 37 weeks onwards, because their body's ready for life in the outside world. So passing meconium at this stage can be completely normal, physiological. It could also be that passage of the meconium is a pressure effect. Sometimes we talk about what we call toothpaste meconium. That is meconium being passed, coming out of the vagina almost as if it's been squeezed out of a tube of toothpaste. A long string of meconium, as it were. This makes us wonder, actually, if the baby could be breech or bottom down. The pressure on the baby's tummy and pelvis as it's journeying down the birth canal can result in the baby passing meconium. And because the baby's bottom is down in the birth canal, the meconium doesn't get mixed in with the amniotic fluid in the same way, but comes out in this long string. It's being pushed out. So toothpaste meconium immediately makes us think, oh, we should check which way up this baby is. Have we missed the fact that this baby is actually bottom down? So we might get the scan machine and scan. In the same way that I said it could be normal to pass meconium if the gut is maturing, if you're preterm or you're in preterm labour, passing meconium is unusual. The baby's gut shouldn't have matured to that level. It could indicate the possibility of infection, and particularly preterm meconium passage can be linked with the specific infection, listeria. Or meconium in the amniotic fluid around a preterm baby can be very concerning to us. It shouldn't be there. It's more likely that it's there for a pathological reason, that is, that there's some underlying problem. So it's important for us to alert our neonatal colleagues and think carefully what could be going on with this baby. Whilst meconium can be normal at term, it can also be pathological, a sign of the baby chronically struggling in the womb and being hypoxic or short of oxygen. This can mean the baby's been under stress. The placenta may not be working as well, and this type of meconium is more common if perhaps the baby is growth restricted or been under pressure in some way in the womb, and is also more common in mothers who smoke during pregnancy or are exposed to smoke during pregnancy. So one of the first things we can think about when we see meconium is what stage of pregnancy is the woman at? Is this something that could be normal, or could this be an indication of an underlying problem? Okay, so we've established meconium. Sometimes we talk about thick or thin meconium. Sometimes we divide it into significant or non-significant meconium. Why do we make this differential? Well, part of the reason is that actually, if the meconium is very thick, it can mean that it's not diluted very much. that might mean that there's not very much amniotic fluid around this baby. And that could be a sign that the placenta isn't functioning as well as is ideal. The amniotic fluid, remember, is predominantly the baby's urine. So the volume of fluid tells us how the baby's kidneys are working, whether they're getting a good oxygen supply and are perfused well with a good volume of blood. So a baby that might be growth restricted or struggling to grow, or whose placenta isn't working very well, may have less amniotic fluid, sometimes called oligohydramnios. And this will mean that when the baby passes meconium, the meconium is mixed in with less fluid, and therefore the meconium may be very thick. So it isn't that the meconium itself is different, it's just that it's been less diluted. In contrast, thin meconium may be there's lots of amniotic fluid, this baby's producing lots of urine, the meconium is very diluted, and therefore it appears to be thin. This may tell us that the baby's already coping quite well. So once we've had a think about whether or not this meconium is likely to have been passed because of an underlying problem, or whether it's just part of a normal process of growth and development, then we have to consider what happens next. Meconium aspiration happens because the baby's gasping. When the baby is born, its face hits the outside world. The cold and the occlusion of the umbilical cord causes the baby to gasp and fill the lungs with air. With meconium aspiration, this gasp has already happened in the womb, and meconium has become inhaled into the lungs, and this can cause a number of problems. One of the easiest problems to understand is simply obstruction. If you've ever looked at a meconium nappy, remember it's this very, very thick, cloying, tarry, greeny black stuff. You can imagine that if you breathe that in, that could obstruct the airways, the tubes that bring the air down into the lungs so that the lungs can't inflate properly. So the meconium can actually occlude and obstruct large airways. But more commonly, what happens is that little lumps of meconium cause partial obstruction, blocking not the big airways, but the smaller airways leading to the alveoli, the little sacs where the gas exchange happens, where the oxygen and carbon dioxide pass between the outside air and the baby's blood. And what happens when those little small airways get blocked is the alveoli overinflate and can, in some situations, actually burst, causing something a little bit like the emphysema that you see in an adult with chronic lung disease. Remember, the meconium is made up of cells and digestive enzymes, and these digestive enzymes cause inflammation and irritation, what's called a chemical pneumonitis. That is, the chemicals within the meconium cause that irritation and inflammation in the lungs, and this can cause stiff lungs. The meconium can also affect the chemical called surfactant. So alveoli, the little sacs for gas exchange, as I've mentioned, they have to open up. And to keep them open, there is something called surfactant. This increases the surface tension, holding them open. The way I was taught about this as a medical student is if you think about a bubble of washing up liquid. So if you have a small amount of washing up liquid and you blow into it, or you have children's bubbles, you blow into it, you blow into a film, you fill the film with air, you create an air bubble. And that is sort of what surfactant does. It creates a bubble holding the alveoli, the little gas pockets, open. Surfactant is really important at the beginning of life to hold the baby's lungs open. Remember, they've been full of water before. And surfactant is a treatment that we use for preterm babies because they don't have enough surfactant, or their surfactant is not sufficiently developed. So babies with meconium aspiration, the meconium affects the way the surfactant works and causes it to work less well, or causes surfactant dysfunction. And again, those nice little air sacs start to collapse. So what we see with meconium aspiration is that the baby's lungs don't work as well. So when the baby's born, it could have significant breathing problems. Now you might think, okay, you've got that moment. You've got the moment when the baby's being born. What if we sucked out the meconium at that point and stopped the baby from inhaling it? When I was first training in obstetrics and gynecology, that is in fact what we used to do. The baby's head would be born, and as it sat with the whole of the rest of the baby still within its mother in the birth canal, we would take a little sucker and stick it up the baby's nose and suck out the baby's nose and mouth. And we would try and do this to clear the meconium before the baby took that first big breath. And when we had a baby with meconium, we were also told that rather than rubbing the baby and drying it down and stimulating the baby to start to breathe, which is normally what we do when a baby was born, as part of the first start of resuscitation, that we shouldn't do that. We shouldn't stimulate the baby at all. We shouldn't trigger the baby to start breathing. First of all, we should suction out the back of its nose and mouth. And certainly when I did my neonatal job, that is what I was taught to do. However, thinking has developed now. And the thinking is that if there's meconium during labour, and the meconium is mixed in with the amniotic fluid, that meconium is already in the lungs. So doing this suction at the last minute to stop the baby breathing it in is ineffective. There's not good evidence it makes a difference. The other problem with meconium is it can make the baby more prone to infection. Meconium itself is sterile, but it can lead to development of infection during labour, or chorioamnionitis. That's infection of the membranes, the chorion and amnion, and the amniotic fluid around the baby, as it encourages bacterial growth because it inhibits some of the white blood cells in the amniotic fluid that would normally act against infection. So when we find meconium in the waters in labour, first thing is check it's not toothpaste meconium and exclude the fact the baby might be bottom down. But then the second thing is to think, okay, what are the chances this is normal physiological passage of meconium? Or is this actually an underlying problem? If there's an underlying problem, we think there's something wrong with the baby that's caused this passage of meconium. We might be more likely to suggest a caesarean birth. But if we think it's a normal passage of meconium and that this baby is healthy and well, and there are signs with the baby's heartbeat that it's doing fine, then there's no need to rush in and deliver the baby. But equally, we don't want to hang about and wait a really long time, because as obstetricians, we've got in our minds the fact that we've got to pick out of the maybe around 20% of all births that will have meconium stained amniotic fluid. We've got to pick out that 2 in 1,000 that will have a serious meconium aspiration syndrome and try and prevent it. So, what will happen? If we find meconium and you're in labour, that's fine. If we can't find any evidence of infection or a chronic shortage of oxygen for your baby, we will recommend continuous heartbeat monitoring so we can watch carefully for any signs that the baby is stressed or not coping well with contractions. And we will also monitor carefully for any signs of infection. We'll aim for a vaginal birth, but we'll have a lower threshold for stepping in and intervening and recommending we do something because we're aware that there is a higher chance of these things occurring. If you break your waters and you're not contracting, where we might normally suggest that maybe you wait for 24 hours to see if you go into labour, if you're not contracting and you have meconium in the waters, we will suggest that it may be beneficial to get on with things and think about having an induction sooner rather than later. That's because we don't want to give time for infection to set in or for the baby to become stressed from a prolonged time with the waters broken. So we're very cautious when there's meconium. So if you have meconium in labour, what will happen when the baby's born? How will we know if your baby has meconium aspiration or not? Well, we will recommend that you have a paediatrician, someone familiar with the signs of meconium aspiration who can assess your baby as soon as it's born. Yes, the midwives are trained in neonatal resuscitation and they can definitely look after your baby should meconium be picked up at the last minute. But if we know that a baby has meconium, we will call a paediatrician to attend the birth as a precaution. If your baby's born screaming, crying, happy, there's no reason for us to take your baby away and do any extra checks at that point, or to clamp and cut the umbilical cord early. The paediatrician will be very happy to leave you and the midwife to it. But if the baby happens to come out floppy and start to struggle with its breathing, then having the paediatrician on hand can be extremely beneficial. Some babies born with meconium will come out and cry and be completely fine, but at a later point start to work hard or struggle with their breathing. So when you've had meconium in the waters during your labour, we will recommend a period of observation after the baby's born. You don't have to do very much, but we will do things like check your baby's temperature, your baby's heart rate, your baby's breathing rate. And if your baby's having difficulties, we will check the baby's oxygen saturation levels by taping a little probe onto their hand or foot with a little thing that looks like a sticking plaster. If a baby's been born through significant or thick meconium, then we will suggest doing these observations for 12 hours. So the observations will be done within 1 hour of birth, at 2 hours of age, and 2 hourly until 12 hours of age. But more commonly, rather than picking something up through those regular observations, the midwives and obstetricians will usually pick up that something is wrong far more quickly, because we're trained to recognise when a baby is struggling. There are some obvious signs, and sometimes the parents will notice stuff themselves. They'll say, Why is my baby making that funny noise? Some babies that are struggling to breathe make a little grunting sound. So rather than being quiet or crying, there'll be a little like that. And it's very distinctive. When you've heard it a few times, you recognise it. The other thing is their nostrils may flare and their chest movements, so under their ribs, will appear to suck in, called recession. So the midwife, sometimes without counting the respiratory rate or checking your baby's heart rate or doing anything that looks like very intensive observation, will say, I'm just going to call the paediatricians back. I'm just a little bit concerned about how your baby's doing. And this is important because babies with meconium aspiration syndrome, even healthy, well-grown, full-term babies with meconium aspiration syndrome can need support with their breathing as significant as being on a ventilator. And this is why meconium, despite the fact it's common, is a very important thing for us to consider and take seriously. Right, what about a zesty bit? I think if you're a member of staff working in maternity services, meconium should always be treated with caution. Sometimes we have debates about significant or non-significant meconium. I think with meconium, always having a good conversation with your obstetric and paediatric colleagues on every individual case and thinking collectively about what is the right thing to do and how likely is it that this meconium is important or could indicate an underlying problem is really critical. If you're a woman listening to this, then I hope that this has given you a little bit of context as to why we're concerned about meconium, what are the things we need to think about, and why sometimes it can feel that some of your choices are more limited. But it's with good reason, because although you may be one of the people that has meconium and it's totally harmless to your baby, we've got to be very cautious and try and help keep you and your baby in that category and not ignore what could potentially be an important sign that could have an impact on the future health of your baby. I very much hope you found this episode of the theobspod interesting. If you have, it'd be fantastic if you could subscribe, rate and review on whatever platform you find your podcasts, as well as recommending the theobspod to anyone you think might find it interesting. There's also tons of episodes to explore in my back catalogue, from clinical topics, my career and journey as an obstetrician, and life in the NHS more generally. I'd like to assure women I care for that I take confidentiality very seriously and take great care not to use any patient identifiable information unless I have expressly asked the permission of the person involved, on that rare occasion when it's been absolutely necessary. If you found this episode interesting and want to explore the subject a little more deeply, don't forget to take a look at the programme notes where I've attached some links. If you want to get in touch to suggest topics for future episodes, you can find me at theobspod on Twitter and Instagram, and you can email me theobspod@gmail.com. Thank you for listening.